Welcome, everyone. My name is Morgan Harrington, and I'm the National Coordinator of Programs here at the American Liver Foundation. I'd like to be the first to thank you today for joining us for our Liver and Heart Health, Understanding and Managing Associated Conditions webinar. ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for both patients and providers. You can find more information at liverfoundation.org. Our new resource is the American Liver Foundation Patient Registry, the first ever patient registry for all types of liver diseases. Our goal is to help researchers better understand liver diseases and learn how these diseases and current treatment options impact patient lives. The registry is open to individuals 18 and older who reside in the United States with any liver disease at any stage, including transplant recipients. Participation is easy and includes a user-friendly online survey that will only take about 15 to 30 minutes of your time. You're welcome to use the QR code that is currently on the screen or the link, and that will go ahead and link you to the Learn More or to be able to participate in the registry. Please don't wait. Your experience is going to help change the future of liver disease. We have two incredible speakers here with us today, Dr. Pranab Barman and Dr. Eduardo Rame. Dr. Barman is a transplant hepatologist and associate professor of medicine at UC San Diego with an interest in how cardiovascular disease impacts patients with liver disease, both before and after transplantation. Dr. Rame is an experienced clinician and researcher specializing in advanced heart failure and pulmonary hypertension with more than 20 years experience in the field. He has led programs both nationally and internationally, focusing on patient-centered care and team-based management of complex heart and lung conditions. He currently holds the Lewis R. Dinon Chair of Clinical Cardiology at Thomas Jefferson University Hospital and serves as the Chief of Advanced Cardiac and Pulmonary Vascular Disease. If you're looking for more information after our webinar today, we encourage you again to visit liverfoundation.org. There, you can also find details about our virtual and online support groups, as well as opportunities to get involved as an advocate. Additionally, you're welcome to explore resources from the American Heart Association at heart.org and the American College of Cardiology at acc.org for further information. We'd also like to invite you to connect with us on social media. You can find us on Facebook, Instagram, LinkedIn, X, which is formerly known as Twitter, as well as YouTube. We look forward to staying in touch with you. As we get started, if you have any questions today, please use the question and answer feature in Zoom. I am now going to go ahead and turn the discussion over to Dr. Barman to get us started today.
Good morning, everybody. Thank you, Morgan, for that introduction. As mentioned, my name is Pranab Barman. I am one of the liver doctors here at UCSD. Thank you to everyone who's joined. So we're here this morning to discuss liver disease and heart health. And I have my co-panelist, Dr. Eddie Rame, who will be discussing more of the heart part of things, but I wanted to get started on the liver aspect of things. And we'll spend a few minutes just discussing kind of big picture about the liver. Some of this may be basic, obvious information to some folks and maybe new information to other folks. So bear with. We'll talk a little bit about different things, different disease processes that can affect the liver, and then we'll end with a focus on fatty liver disease, as that's probably the single biggest liver disease that has a strong connection with the heart, and and there's a number of different aspects that we'll discuss. we've kept the presentation part of this relatively short, and invite a lot of questions and discussion afterwards to just to move this forward and have more of a discussion between Dr. Rame and I and you all. So just kind of briefly, excuse me. What is the liver? It's the second largest organ in the body, the skin being the largest. Some fun facts about the liver. It about 1.5 liters of blood flows through the liver per minute. And that'll become a little bit more important later today. It has the capacity to regenerate itself. And there's a caveat here that it has that capacity up until a certain point. And that point is when the development of scar tissue starts to occur in the liver. And and that's a very important thing to keep remembering as we talk about liver disease, liver damage, and what we call end-stage liver disease. And we'll touch on that in a few slides in terms of the details there. I like to include this point here because the liver has a very mythical, legendary status as having this capacity to regenerate itself. But we have to just sort of temper that approach and that sort of assumption with a better understanding of what the liver can and can't do. Technically speaking, the liver has over 500 functions, but but we talk about a little bit about what those functions are a little bit more specifically here. Um, so in ancient times, the liver was actually considered to be the seat of inner emotions and the repository of life. Um, and I think that's why it was given the name the liver. As we have learned more about the liver, as science has advanced, we now understand what the liver actually does. It has nothing to do with emotion. Well, maybe it has something to do with emotions, but for the most part, the liver now is important in making clotting factors, detoxifying our blood. Many of the toxins that come into our blood are from our gut, so there's a very strong connection between the liver and the gut as byproducts of the food and drink that we consume. Along the way, it also regulates blood sugar and cholesterol, and as a product of that uh, processing of all of our food into fats, proteins, and carbohydrates, it makes bile as essentially another agent that helps us digest that food. It's responsible for a big part of our immune system that helps us fight infections. And it is the source of what we call quick energy. Uh, for example, if you needed to run or do something extremely quickly, your liver produces glucose that allows you to do that instead of waiting for your body to break down other portions of nutrients that are stored. So it's a very important part in our sort of day-to-day life, and for these reasons and many others, we've got a very important point of the liver here in terms of its functions. So, what happens to the liver, I think, is a really important thing to understand. And there's certainly some scientific words on this slide, but we will work on understanding that. Um, w- I see patients day in and day out who come into my clinic who are worried that they've been sent to a liver doctor and their liver is failing. And I think it is important, while that may be true in some cases, it's important to understand that there is a large spectrum of disease and a large spectrum of injury that can really happen before we get to that point of liver failure. Many people that I see in my clinic are come to see me because of elevated liver tests. And elevated liver tests is not liver failure. And I think this is an important thing to really just pay attention to upfront. Elevated liver tests or early forms of liver damage are the beginning parts of of this sort of spectrum that you see here. Oops, sorry. I'm going to just pull out a little laser pointer. So when you um, when you have a healthy liver that uh, incurs some kind of injury to that liver, which would be these two stages here, um, you you will end up in a situation with liver tests being elevated. Um, and that injury could be could be fat being put into the liver, or inflammation. Um, inflammation being with various different causes of inflammation. But the important part to understand is this is where things can be reversed in the spectrum of liver disease, and 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 this sorry this uh is where things can get better if we intervene and can prevent the progression going forward. So when we talk about the liver having the capacity to regenerate itself, it's all in this section of this spectrum. Once the liver starts to develop scar tissue, it becomes a lot harder to reverse that injury and inflammation. And essentially, what's happening between this stage and this stage is that the liver is trying to regenerate itself, is trying to heal itself, but as a byproduct of that process, starts to it develops scar tissue within the liver. The easiest way to understand this as well is if you think about a cut or a scrape that you may have had when you fell or for whatever reason. Your body will try to heal that, right, by producing a scab and everything. And then at the end of all that process, you've got intact skin, but there's a scar there. And that's the same process that goes on in the liver. And when you develop enough scar tissue, you end up with a diagnosis called cirrhosis. And even at that point, patients with cirrhosis can still have intact liver function, and some patients then develop liver failure after that. And that's a little bit beyond the scope of this talk today. But the point being here is that liver failure is on this end of the spectrum, and there's a lot of room and a lot of space before that to intervene and prevent that development. So the what diseases can affect the liver? The list is quite long, and some of these may look familiar to you, and some of them may be new diagnoses. And um, perhaps the three most common diseases are alcohol use disorder, fatty liver disease because of metabolic disease, and we're going to talk about that in more detail, and then hepatitis C. Those are probably the three most common diagnoses in the United States. Um, the others that are listed here are a little bit more rare, but certainly do happen. They are essentially grouped into genetic disorders, immune system disorders, and bile duct disorders. Again, all of these disease processes to start with with a inflammation or fatty liver component to it. And as the liver tries to get better, they can progress to the development of scar tissue. So let's just talk a little bit about fatty liver disease because this is going to set the stage here for the connection with the heart and a bit about what Dr. Rame is going to speak about here shortly. So what is fatty liver disease? It's pretty simple. It means that there's fat in the liver. That's pretty much it. The main causes of fatty liver, though, are kind of twofold. Alcohol and what we refer to as metabolic associated fatty liver disease. Now, metabolic associated fatty liver disease is a common condition that occurs in patients who have diabetes, high cholesterol, high blood pressure, and who are obese. The point there is that again there are stages of that fatty liver disease. So patients can have simple fatty liver disease. They can have some inflammation associated with that fat, the development of scar tissue, and then ultimately cirrhosis. And so that spectrum again exists within the the diagnosis of metabolic fatty liver disease as well. And so keeping that in mind as we discuss sort of the basics and then the end stage of liver disease. Certain medications, certain genetic conditions, these are much more rare, and even situations associated with rapid weight loss, such as bariatric surgery, can also lead to fatty liver disease as well. But by far, the two most common conditions are alcohol fatty liver disease and metabolic associated fatty liver disease. Specifically about metabolic fatty liver disease, it's estimated that up to about 25% of the US population has metabolic fatty liver disease, which is quite a lot of people. Um, about 60% of diabetics and 90% of obese patients have some form of metabolic fatty liver disease as well. And remember, that can be something as simple as just fat in the liver. I like this slide because it really, excuse me, it really touches on the progression of fatty liver disease. So here you've got a healthy liver, and this is obviously a schematic. Here you've got fatty liver, so you can see that there's now fat droplets more so than in the healthy liver. That the yellow globs are the fat droplets inside the liver. The fat shouldn't be there. The liver tries to get rid of it. And in the process of trying to get rid of it, develops inflammation and then scar tissue, which occurs in between the liver cells. And ultimately, when you've got enough scar tissue, can be diagnosed with cirrhosis. A couple of key important points here is that you'll see there is a reversible tag listed all the way until this part here. So just another reminder that liver disease is reversible until the point that you develop significant scar tissue. And then it's generally thought of that if you took 100 patients that had simple fatty liver, about 20 to 25 patients will develop advanced disease, and about 4 patients will develop cirrhosis. The problem is we don't know which patients will progress down the line and which patients don't progress down the line. And so for that matter, we take this all quite seriously, and we are very keen to make this diagnosis. How do we make this diagnosis? Usually it's by an imaging test when we evaluate elevated liver tests. We'll rule out other forms of liver disease along the way. And the trick here is that a lot of patients will come in with just elevated liver tests and no associated symptoms. And that's an important thing that it does not, many of my patients will ask me, I don't feel anything. Well, that's okay because fatty liver disease oftentimes does not lead to any symptoms or any feeling, any sort of thing that you'll necessarily feel. Your liver doctor may talk to you about a liver biopsy, but we also now have some good non-invasive tests as well that are useful in staging the disease in terms of the spectrums that we've talked about. And we talked about these metabolic risk factors. The management of fatty liver disease is a lot of what you probably have already imagined, which is healthy eating, low carbohydrate, low sugar diet, daily exercise, and elimination of alcohol. It's essentially a focus on a healthy lifestyle. That's important. Um, and and just to finish up, why do we care about this? Of course, fatty liver disease can progress to cirrhosis and signs of liver failure and even put you at risk for developing liver cancer. But we've also learned more recently and more importantly is that it's associated with chronic kidney disease, coronary artery disease, congestive heart failure, and cardiac arrhythmias. And that's actually sort of the point of this webinar this morning is to discuss more about the risk with heart disease that's associated with fatty liver disease. I'm now going to turn it over to Dr. Rame, who will walk us through some of the key components related to heart failure, heart disease, I should say, and liver disease from a more general perspective.
Good afternoon and good morning. Can you hear me okay?
Yeah, we can.
Okay, wonderful. And I want to thank Dr. Barman, first of all, for doing this together. And we've been exchanging some emails and some thoughts on, maximizing the ability for the seminar to provide good information to our colleagues, to our patients, and especially to help the wonderful work that the American Liver Foundation does. So I'm going to start with this illustration because what we really want to, I guess, convey here as we transition to my part is the overlap between liver and heart and what the seminar is about. It's about organ dysfunction. So what does that mean? Dr. Barman gave very good oversight of the way that you get progression of liver disease over time, starting with the different lesions that can affect the liver, including alcohol, as well as increased caloric intake, diet-induced obesity. And I think what's important is to say that, you have the risk factors, you have a disease state that's identified, we have biomarkers, liver function tests, and you ultimately get organ dysfunction over time. And part of, I think, what should be a keen objective from us as clinicians, from patients as their own advocates or providers, patient advocates, caregivers, family members, is how do I prevent disease progression? How do I prevent organ dysfunction that leads to, in the case of liver disease, clinical cirrhosis at the end stage? In the case of heart failure, we talk about the advanced stages of heart disease. So what this illustration really nicely puts together is, let's talk about first the direction that Dr. Barman was discussing. Let's talk about how liver disease and liver dysfunction can affect the heart and give it a little bit of more understanding. So first of all, and I'm so glad part of the focus is fatty liver. Again, non-alcoholic fatty liver and fatty liver in general. It is extremely important, especially as we're delving into how to reverse and improve diet-induced obesity with agents that are now becoming more available for our patients, to understand that fatty liver is not only an associated risk factor. So you say, well, why would fatty liver be associated with heart failure? One, again, not completely studied. This could be the basis for a wonderful, multi-center study that looks at this. But one of the things that's important is the overlap with obesity, with fatty liver, as well as with heart failure. And you do have, in the case of obesity, an important risk factor for developing heart failure with a preserved ejection, meaning that your heart is squeezing well, but it's not relaxing well. And furthermore, for reasons beyond just relaxation and squeeze, you start developing a state of breathlessness. You start developing a state where you are developing fluid retention. And so that's an important, that's an important direction we're going to go ahead and just briefly talk about. Importantly, if you develop more advanced liver disease like cirrhosis, we're going to briefly touch upon the issue of how the physiology of cirrhosis affects the heart. I mean, the heart and liver, like the heart and kidney, like the liver and kidney, I mean, these are very, very, these are organs that are talking to each other in many, many ways, not just through the circulation. So cirrhosis is a state where we know in certain patients, you get heart dysfunction. And it's tricky because your heart can look strong on the imaging we get. But then when we challenge it with things like exercise, or we try to increase its heart rate with medications to really test the reserve of the heart. And we do this in patients that have symptoms, obviously. We're not doing this in everybody. Or we do it in patients that are progressing to liver dysfunction so quickly that they're going to need a transplant, like what Dr. Barman and his colleagues do. Importantly, that state of cirrhosis can lead to we call it a high output, highly working heart that becomes over time dysfunctional. You can imagine a heart that does not have to generate much flow, but is asked to generate flow because of the environment of cirrhosis. It's going to get sick over time. Not all of them. Again, the human, as Dr. Pranab and I have seen in many, many, instances with patients, patients adapt differently and they have different levels of reserve. But that's the cirrhotic cardiomyopathy component. We're not going to talk a lot about post-liver transplantation, but I'll just mention that it is very important for all of the folks to know on this call that we work very closely together, the heart teams and the liver teams, to make sure we understand the risk of someone undergoing liver transplant. And we also need to understand the risk of someone undergoing heart transplant if there is chronic liver or high risk factors for liver disease or disease progression. So now let's look at the other arrow. I don't think you can, maybe you can. So we just did that arrow. Now let's at the other arrow from cardiac dysfunction to liver dysfunction. This is where we need to understand the circulation, which I'll go into in a little bit, of the hepatic circulation. But importantly, this is one of the most important reasons why patients with heart failure progress, heart dysfunction progress, acute heart dysfunction, like when you're having the unfortunate event of a heart attack. If the liver is involved and it's actually significantly involved, it's going to complicate the way the patient recovers from a heart event. It's going to complicate the way a patient can survive heart failure. So I just want to give a little bit of a shout out to some colleagues that are studying this axis, this cardiohepatic axis. One of the colleagues is actually in Czech Republic at the ICHEM Institute. And this is Wojtek Malinovsky, who's been interested in how the progression of heart failure ultimately, when the liver becomes more diseased from that because of congestion. So the liver sits basically just south, if you will, below the heart, and it's connected. We're going to look at circulation in a minute. But when you congest that liver over time, many investigators have identified that that's when the patients begin to get really sick. In fact, they don't eat as much, they start losing weight, and they get into a metabolic syndrome that I'll just finalize at the end and with a nice slide show you what that looks like. So we talk about cardiogenic liver injury, that's acute. We're talking about congestive hepatopathy, that's more chronic. Thank you so much. I don't think I can advance the slides, but Dr. Barman or Morgan. Oh, thank you. This is just real quickly the hepatic circulation, just to be on the same page. The important take-home message is when you have cardiac dysfunction, you are affecting the liver at both ends, at the input from the aorta or the systemic circulation, as well as the congestion, the backflow from the heart that comes from the heart failing. You get backloading from the inferior vena cava. What happens is these sinusoids, which are basically the merging small blood vessels that allow the liver to get incredible, quick, and amazing perfusion, which is, as Dr. Barman mentioned briefly, I mean, the liver is an amazing organ, being able to do so much in terms of metabolism, in terms of, clearance. I mean, I'm going to just not mention more because I am a heart specialist, but I appreciate our colleagues from the liver team knowing that, we work closely because we know how much these organs affect each other. But safe it to say that this is a dual circulation, and you have the ability for the liver to get perfused through the portal venous system, as the splanchnic circulation basically provides nutrition to the gut. And then that large bed of circulation then goes on to drain to the portal venous system that then goes to the liver for further metabolic processing and further input. And then you have the arterial system. So hopefully you understand that this is very important to at least have a concept that you can have heart disease affect the liver just because of heart dysfunction. You also have conditions like atherosclerotic vascular disease and cardiovascular disease, where you have not just coronary artery involvement affecting heart function, but you actually have, unfortunately, arterial disease involvement that we're not going to talk much about, but I want to highlight that arterial disease involvement would also be a very important component. Next slide. Now I want to just get into a little more of acute and chronic liver injury briefly. And this, for our participants, we really want to give you an understanding of how important it is for a liver patient, or if you're the caregiver for a liver patient or the provider, you know, I think we have to start thinking a lot more about how the heart and liver axis, the interactions, can make the liver over time worse. I have no doubts that if you are a patient that has risk factors for bad heart disease, it's going to affect how well your liver stays well and healthy. I'm not an expert in advanced liver disease, but I do see a lot of patients from our liver colleagues that come see me when they're at risk for not doing well either with liver transplantation, or when they have questions about the congestion to the liver. So this is just the two pathways we talked about. The acute cardiogenic liver injury, what does that mean? That means if the heart's not able to sustain a patient because of a heart attack, because of chronic valvular disease leading to progressive heart failure, many, many, many different reasons, you will make the liver sick from ongoing ischemia. That means you are not giving the blood flow, that rich blood flow the liver needs, it's not getting there. And those are repetitive hits over time. And we see that. We see the patients when they come see us with worsening heart failure have evidence of chronic liver congestion and chronic liver disease. So that's one important component. I also want to just, if we're talking about patients that have cirrhosis or that have really advanced liver disease, I think these are patients that, as long as they're doing the best they can to stay heart healthy, it's hard because often these patients have fluid overload. They need diuretics to get adequate fluid off, and it's hard. Some of them are breathless. But I think it's important, if they're not achieving their goals of performance and exercise or whatever their liver physician and primary physician want them to achieve, make sure you get a chance to visit with a cardiologist that can optimize potentially all the risk factors that you may not know you may be subject to, including risk factors in the setting of diet-induced obesity that include heart failure, that we're seeing more and more patients that have a strong heart, but heart failure because they have a component of preserved ejection failure. So this is just a summary here of the different stages where, you can start with changes in the shape of the heart when your liver's getting worse. We see that. That may not impact much. That's just the adaptation of the heart. Then you get into function of the heart. That could impact, obviously, your symptoms and not allow you to live as active a life as you want to. Then the heart starts impacting the liver, like we talked about. So if you start with a liver that's impacting the heart, then the heart impacts the liver. And when you get into the end stages, we are talking about having of liver disease, as well as advancing stages of heart dysfunction. We are talking about scenarios that can really decompensate the patient. So that's a nice slide that gives you that kind of idea between the two organs. And this is just the wrap up now. I just want to make sure that, there's some element of detail for our providers, our interested patients, in terms of the metabolic syndrome of diet-induced obesity. We are talking about the fact that, in the setting of fuel excess, fuel surfeit, we do see patients that develop from the increased breakdown of lipids, the increased adipose mass. We see patients having these deposits, these fatty deposits that lead to insulin resistance. And it's important to know that here's the non-alcoholic fatty liver disease stage. This is why it's so important to, if you have a condition of, hepatic steatosis, think about the effect that this may have, along with other risk factors, on your heart. Because we do see patients that get the heart dysfunction I talked about. The squeeze looks good. And if you just ask anyone to provide input on how your heart's doing, they're going to look at a heart that's squeezing well. They're like, well, it's important to lose weight, important to stay healthy, eat healthy foods. All of that's good, but it's also important to keep your eye on If you're getting worse from a fluid perspective, retaining fluid, it may not be cirrhosis. It may be heart failure. And that's an important thing to distinguish. And the final slide here is more in terms of the end stage of heart failure. So we have the metabolic syndrome of diet-induced obesity, and then we have a very interesting overlap syndrome. I mean, you have the patient losing weight as they have worsening heart failure. Why? Because their heart's not supporting their body. And it's complex, the issue of cardiac cachexia and cardiac-related weight loss from heart failure. But just suffice it to say, we know that at that point, we really want to make sure that patients are able to be seen if they're losing weight in relation to heart failure. And some of these patients have congestion. That was the important contribution of the gentleman from Prague, Dr. Malinowski and other colleagues, is that once you start congesting that liver and they see changes in the liver, congestion, often weight loss is hitting that patient. So that could be an important nexus to also consider there. This picture is just there to show that you still have, unfortunately, a condition as you lose weight, a fat breakdown, and we still have to deal with that fat in the muscle, in the periphery, in the liver. So it's important to be aware of that as well. I'm going to turn it back over to our, I guess, Morgan, the overall panel and with Dr. Barman and I, and we can just see what kind of questions we have in the chat. Thank you.
Thank you both. And I truly appreciate your flexibility. I know technical issues can always come up when we are on a live event, of course. So I appreciate both of you being so on it with everything. We did have a couple of questions come up in the chat. The first one was, can you tell whether fatty liver disease came from poor diet or alcohol? Are there any markers or maybe signs or symptoms that you can recognize? Oh, sorry,
So,
Dr. Okay, there you go. I'd say we couldn't hear you for a second.
so I think the long answer, or the short answer, is that it's challenging to identify fatty liver from alcohol or metabolic disease just based on an ultrasound finding. What we do use is other markers, other blood tests, our history taking in terms of amount of alcohol, other risk factors, to understand if there is a larger component or a larger driver of the fatty liver disease. And certainly there's a lot of overlap. On one end, you have patients who only drink and are maybe young and don't have metabolic conditions, and other patients who have just metabolic conditions and don't drink. And on a biopsy, those will look different, but on an ultrasound, they will actually look the same. And then, of course, there's a big spectrum in the middle of patients who drink a little bit, who drink moderately, and that's certainly much harder to tease out, quote unquote, where did the fat come from? At the end of the day, that lifestyle adjustment is important because where the fat came from is only important to know how to properly adjust the lifestyle, if that makes sense.
Yeah, absolutely. I appreciate that. And it's sort of along the same lines. I guess the question really reads is, if you have liver disease, should you give out alcohol altogether, or is 1 to 2 drinks a month or something along those lines okay?
So this is another good one from the perspective of just the controversy behind it. The purist and a liver doctor will always recommend to eliminate alcohol, to eliminate that as a potential contributor. And certainly this is a discussion that can be had with your doctor, but the idea behind avoiding alcohol, exercising, and eating well is to optimize your liver health. And so if you are someone with, let's say, early or simple fatty liver disease, your needs to optimize your liver health are very different than someone with more advanced liver disease. And so I think that's where the conversation changes. And along the same lines, we can think about that as, there are new medications, as Dr. Rame alluded to, about fatty liver disease. but someone with simple fatty liver disease may not need those heavy dose medications. Someone with more advanced disease might. And so alcohol plays a similar sort of concept as well. In general, our sort of party line is that as we're figuring this out and trying to help take care of your liver and optimize liver health, alcohol should be avoided as much as possible.
Dr. Rame, I want to also pose that similar question to you. If someone is experiencing maybe a little bit later heart disease, later stage heart disease, would you suggest that they give up alcohol?
This is where it's nice to have both Dr. Barman and I here, because I think it would be interesting to, so I'll share the guidance documents that have given us recent data that we really want patients with advancing heart failure to stop drinking completely. At one point when the heart becomes sick, it's not working as much, not as strong. Almost any degree of alcohol can be, as we use the word cardiotoxic. And I think if you have already a state where you are what I can't not be certain of is if the risk is even more additive or multiplicative if you have heart and liver disease jointly in the setting of heart failure, right? I mean, that's an interesting question. I mean, those patients, frankly, often are being looked at for heart transplantation if their liver is good enough. And this is a very difficult area to have absolute clarity on, but we have some guidance on that too recently. Or some of these patients are being, as Dr. Barman knows, being looked at for dual organ heart liver. If you're being looked at for a dual organ heart liver, you really should be completely free of alcohol to give yourself a chance as you await your transplant to survive.
Yeah, that's a great answer. And I appreciate that kind of holistic, full approach from both organ systems as well. One of the other questions that kind of came up in different forms throughout our questions is related to food. And one of them asks if you have any good resources for liver and heart friendly diet. And I am going to shamelessly plug our menu that we have built out this past year here at the American Liver Foundation, and we'll drop that in the chat. But I'm also curious to hear what you all utilize in your practices in terms of offering suggestions for individuals who maybe are struggling with that diet lifestyle component, and how, I guess, are there certain foods that maybe you suggest, certain diets that you suggest? And then for the people who do struggle with those dietary changes, what are your recommendations to help them be more successful?
I can go first and then I'll turn over. I see a few questions in the Q&A, so I'll try to answer all of them at once if we can. So from my
Dr.
perspective,
Barman, I'm going to defer to you because I don't know how to get to my Q&A here. I'll find, oh, there it is. Now I saw it. Go ahead.
So from the liver perspective, I actually try to keep it quite simple. And I think the focus is not about restriction, but more about moderation and choice. And so early on in liver disease, especially fatty liver disease, what I stress is the Mediterranean diet, something that can be easily Googleable. Oftentimes, physician offices will have handouts for them for patients as well. The Mediterranean diet, the crux is that it's a focus on low carbs and low sugars. So while that sounds restrictive, I think what it really means is cutting out unhealthy foods. And that's I think the most important thing that can happen, because sometimes when I'm discussing with patients, it turns out that breakfast involves a 20-ounce Coke. Later in the day, there's a cinnamon roll that's involved. There's always ice cream at the end of the night, right? Those are the things that actually make the biggest impact when we talk about restriction. And it's not so much that we need to limit how much protein we eat or how much vegetables we eat. Actually, that's the stuff that needs to replace the unhealthy foods. And so I start on the early form of things. I start with a Mediterranean diet. And then if people progress to liver disease, what I encourage them to focus on is the protein, because protein is consumed very rapidly in patients with advanced liver disease. So then it becomes a concept of focusing the protein intake among on top of everything else. And I think that is how I approach the dietary thing. And I don't try to be very restrictive because I know it can be challenging. There are cost concerns, there's food access concerns, there is cooking concerns, and so those are all need to be managed as well.
Let me just say, I wish I could have taped what Dr. Barman said. I guess we are taping, so I'll clip that so I can have my patients understand. And patients at risk for organ dysfunction, for chronic organ failure, chronic organ disease states like ours. I would say that the only thing I'm going to add is at what stage or what is your phenotype as far as weight management, right? So if you have diet-induced obesity, and you're at a very early stage where you may not even know if you have heart failure. And again, we talk about that association between diet-induced obesity and heart failure. I don't want people to get scared about that term heart failure. It's there to help prevent worsening symptoms. It's there to help people recognize that there's ways to treat it. We've just had two important publications in the New England Journal of Medicine, which show that you have with weight loss management medications, such as the GLP-1 and GLP axis of drugs, these are impacting with weight loss improvements in heart failure. And it's remarkable how we felt like we could advise patients of that before, but now we have the data. This is for heart failure with preserved ejection, not heart failure with weak hearts. That is an area that's extremely important to investigate and not take any assumptions for. But I will say that I loved what he said about the latter part of his comment about catabolic states like liver disease and heart failure. These patients are wasting when they're if you're in the more advanced disease stage. So if you're in that early, if you have a fatty liver with heart failure and preserved ejection, you want to find ways to lose weight. There's weight loss management, and I love the Mediterranean diet. And it's not just because I'm Mediterranean. I think it's actually very important. I actually also will add that if you're losing weight with chronic heart failure, chronic liver disease, you have to talk to your doctor. So one of the most important things that I ask as an advanced heart failure physician, I ask for the patient to give me their ID, not to check their age. I'm looking at their ID, their license often is 3, 4, 5 years out. And you can see a difference in the way the patient looks just in the clinic with you and him or her. I can tell you, I do that because the patients often don't realize they're losing weight. Then they say, oh yeah, just 3 years ago, yeah, I guess I was 20 pounds heavier. That is cachexia, especially if it's unintentional. So that's where I think, Morgan, the important thing is what he said about, hey, you got to eat well. We also have to figure out how to reverse the organ failure so that it'll eat, and that'll be correlated with increasing weight and so forth. So I think that's a complex topic, but I think I would advise, and the American Liver Foundation, you guys have been amazing reaching out to us throughout the phase of getting this together. I think nutrition is vastly understudied in heart failure, in heart disease. And again, it's not because we don't appreciate it, it's because we just don't have, there's not enough, colleagues that are out there funded and working on this. There's just not enough data out there on nutrition and diets in our field. I'm not sure about liver.
One quick sentence, I totally agree with that, especially the latter part. There's a lot to be said and learned about nutrition and liver disease. We're starting to understand it. There's just one quick question in the chat that I wanted to make sure we answer. At no point should any liver doctor be telling you to reduce protein in your diet. So if the question is, do I increase protein? Because the answer is always protein is always good. And so I want to make sure that gets conveyed, because that was an old line of thinking. And this is the kind of stuff that in terms of nutrition and nutritional knowledge, we're all starting to come to grips with just as a hepatology community as well.
I appreciate you addressing that. We are running a little bit short on time, so we're going to try to get to a couple more quickly here. And one of the things that came up a couple of times were about autoimmune diseases. Are there any medications that are maybe for liver autoimmune diseases that may negatively impact the heart? And alongside of that, one of the questions also specifically had mentioned treating excessive bile salts. And so they had asked, could those bile salts hurt my veins and arteries as well? So kind of a double-ended question there in terms of, are autoimmune liver diseases having negative impacts on cardiac function? And then also, more specifically, could bile salts for a more broad liver disease concern negatively impact the heart as well?
Regarding autoimmune liver diseases, the simple state of inflammation could have some maybe microvascular impact on blood vessels in the heart and around the body. I think that's why it's important to diagnose and treat early. Most of our autoimmune disease medications, the very specific ones for the liver, don't have much impact on the heart that I'm aware of. The one to keep in mind, though, is we oftentimes use prednisone in autoimmune hepatitis, and certainly prednisone has a lot of whole body systemic side effects in terms of weight gain, blood sugar management, fluid retention. So we are also mindful about not leaving prednisone on for a very long time. I'll just quickly answer the bile salts question. Thankfully, the bile salts stay within the bile ducts and the intestines and then get recirculated back as healthy bile salts through the blood back to the liver. So bile salts, while the name sounds kind of dangerous, thankfully doesn't have any known risk to the blood vessels around the body or the heart. I'll turn it over to Dr. Rame if I got any of that wrong.
Oh my God, please. No, I learned a lot from Dr. Barman. That is exactly the bile salts. I would have deferred to him, and I'm not more of a muscle guy. I take care of patients with sick heart muscles. So I would have to ask my colleagues from the lipid, the bile salt question. But again, I do believe we do not have a reason to be concerned about bile salts from the point of view of, I mean, in fact, they actually could be supportive of lowering cholesterolemia to some degree. So that I would agree with. It's very interesting that you know, when we start thinking about that the first part of the question with autoimmune disease, I would just say that if you have a heart failure risk and you're on autoimmune medication, especially some of these are now becoming more like biologic agents. They're complicated as far as their, these biologic agents that are targeting antibodies and all these different pathways. I think it's important just to have your primary care physician aware if you have also, significant heart condition. The hepatologist works very closely with the cardiologist on all this. So I think that's already been covered. But I think for the case of advocacy for yourself as a patient. For example, if you are someone who's chronically on Plaquenil for a different autoimmune disease, Plaquenil can have an effect on the heart long term. And it's not an easy diagnosis to make when you have a Plaquenil-induced, what we call cardiomyopathy or sick heart syndrome. But thank God, Plaquenil is not used as much as it used to be used because now we have a lot more better agents.
I appreciate that. And we are out of time, unfortunately, today, but we will take these questions and we will do our best to get appropriate answers. And when we send out our thank you email, once our YouTube link goes live for the recording, we will go ahead and add some of those answers into that email as well for everyone. But I just wanted to thank everyone for being here today. Dr. Barman, Dr. Rame, we really appreciate your valuable insight and all that you presented for us today. And we are just grateful for your flexibility and your willingness to be here with us.
You're too kind. It was a pleasure. Pleasure, Dr. Barman. Nice meeting you.
Thank
was
you
great.
so much. Have a wonderful week.